Welcome everybody to this EU IPFF webinar on COVID-19 and pulmonary fibrosis. This is the first of a series of monthly webinars EU IPFF will be organising in the lead up to the European Pulmonary Fibrosis Patient Summit, which is going to be held next April. My name is Steve Jones. I'm the president of EU IPFF, which is a grouping of 21 patient organisations from 15 different countries across Europe. I'm also the chair of the UK charity, the UK patient organisation, Action for Pulmonary Fibrosis. As many of you know, we had planned to hold the European Pulmonary Fibrosis Patient Summit in April 2020, but because of COVID-19, we had to postpone, and we're now going to run it as a virtual summit from the 23rd to the 25th of April next year, 2021. And shortly after the new year, you'll be able to register for taking part in the summit on our website, but not before then. We were very disappointed to postpone because we'd got a great program set up with lots of exciting speakers and some great events. But it's the right decision to make. And as it happens, I'm pleased to say we have one of those exciting speakers with us tonight. It gives me great pleasure to introduce Professor Gisli Jenkins from the University of Nottingham in the UK. Gisli is a leading global researcher on interstitial lung disease, one of the rock stars of ILD research, and he is going to talk to us today about the relationship between COVID-19 and pulmonary fibrosis. His talk will be based on pioneering research which he has undertaken and led on the impact of COVID-19 over the past 9 months. So it's really current and really up to date. This year, Gisli was awarded the European Respiratory Society's Gold Medal in recognition of his 25 years of excellence in research on interstitial lung disease. He's also a founding trustee of Action for Pulmonary Fibrosis, which we set up in 2013, and he remains a trustee and a great supporter of APF. Some of you may have noticed on Twitter this weekend that Gisli completed a fundraising challenge for APF on Sunday by riding his bike for 10,000 miles, 16,000 kilometers this year. I mean, I don't know, it works out at something like 18 or 20 miles a day. And he did it at a speed of 28 kilometers an hour, which I think is faster than I've ever been on a bike. So Gisli is a many-faceted person. Gisli's going to talk today for 20 to 25 minutes, which should allow us, hopefully, 30 minutes for Q&A. We'll be finishing promptly at 8 o'clock Central European time, 7 o'clock UK time. Could I please ask you to submit any questions you would like to using the Q&A, which is on the screen at the moment, the Q&A function at the bottom of your screen. Can you see it, the Q&A, and you write it in the box there? Please do not use the chat function. The chat function is only going to be used by those of us presenting today. And when you submit your questions, please complete them. Please give us rather complete questions and make them as succinct or as brief as possible. Please don't enter any other comments in the Q&A, general comments on ideas you may have, because it's going to clog the system up and make it difficult for me to read all the questions. If there are questions that we don't get to tonight because we run out of time, Gisli has kindly offered to provide written up responses to that, which will be available on our website. The webinar today will be recorded and will be available soon also on the EU IPFF website. I think that's everything now. So without further ado, it gives me great pleasure to welcome Professor Gisli Jenkins and invite him to talk to us about COVID-19 and pulmonary fibrosis. Over to you, Gisli.
Thanks very much for the kind introduction, Steve. And I'll crack on to talk about COVID-19 and pulmonary fibrosis. With the slide. There we go. So I'm going to talk about three things. Firstly, will COVID-19 promote pulmonary fibrosis in people who have normal lungs before they get COVID? And will that lead to a resolving condition or a progressive condition? And then I'm going to talk about what the effect of COVID-19 is on people who already have pulmonary fibrosis, before discussing some of the ways that COVID-19 might impact on the management of people who have pulmonary fibrosis. So COVID-19 is caused by the SARS-CoV-2 viral infection, and at the latest count yesterday, there are 63 million cases worldwide so far, which have led to over 1.4 million deaths worldwide. And the risk factors that are well recognized now for having a poor outcome for infection with SARS-CoV-2 are increasing age, particularly over the age of 55, male sex, and comorbidities, most notably hypertension, type 2 diabetes, and ischemic heart disease, but others as I will come on to. It's worth also noting that these comorbidities of hypertension, diabetes, and ischemic heart disease are linked to other conditions, particularly fibrotic conditions such as idiopathic pulmonary fibrosis. So when we were considering the risk of fibrosis related to COVID, we thought we should start by looking at viral infections generally, because there's long been appreciated by clinicians around the world that patients with pulmonary fibrosis often tend to develop their condition after an apparent viral infection. And there's not really been any great data to confirm or refute whether viral infection, viral pneumonia, can cause pulmonary fibrosis. So we undertook a systematic review, and we looked at two broad categories of virus, the influenza viruses and the coronaviruses. And these are data which were done by Laura Fabry, who's a PhD student in my lab. And basically what she looked at was the CT scans of patients who had been reported as having influenza or coronaviruses, predominantly SARS, because the data are available for SARS, and also for MERS and COVID, but there's less data available for these conditions. And then she just divided the scans into whether they had evidence of inflammatory problems or fibrotic problems. And what you can see in the top two panels is that at baseline, patients with influenza have quite a pronounced inflammatory interstitial lung disease, which then gets better over time. You look at this big blue circle here going to this circle here. There's not so much fibrosis at baseline, and it doesn't really change over time. So influenza does seem to lead to a little bit of fibrosis, but it's not substantial, which would fit with what we observe in the clinic. In contrast, SARS infection leads to a lot of inflammation at baseline or early on in the disease course, but it doesn't seem to change much. Similarly, there's a bigger fibrotic burden in patients who have suffered from SARS. And again, it doesn't tend to get better over time. And this is a concern to us because COVID is much more likely to be like SARS than it is influenza. The viruses are very similar and they cause a similar syndrome. And if we look at how this affects lung function, we look at lung function in two broad ways. We look at the effect on gas transfer, and that's the ability of the lung to move oxygen in from the airspace into the bloodstream. And, and what we see here is that with influenza, there's some effect on gas transfer, but it's much worse in SARS and MERS. We also see that it doesn't really change much over time. So again, the damage is done, but it tends not to get better over the course of 12 months. However, when we look at spirometry and look at the effect on things like forced vital capacity or total lung capacity, there is less of an effect. So the damage that we see observed in viral infection affects the alveolar capillary membrane much more than it does the overall lung volumes. And we can see this radiologically by looking at this time series of CT scans. And this is a patient before obvious COVID, and you can see normal looking lungs with quite nice lung volumes. But over the course of 3 weeks, there's severe inflammation with some evidence of early fibrosis observed by traction change. And this progresses dramatically over the course of 6 weeks with considerable traction change and occasional areas of honeycombing. Again, suggesting that SARS and SARS-CoV-2 are really quite fibrogenic. In some patients who have unfortunately passed away of COVID, they've had postmortems of the lung. And we've stained those postmortem lung sections with a stain called Sirius red. And Sirius red stains up collagen and matrix very nicely. And what you can see is you get these thick fibrous bands within the alveolar units, which we see. And this is, again, evidence of quite severe fibrosis in patients who have unfortunately passed away of COVID. We've got some emerging data looking at lung function from patients with COVID. And very similar to SARS, what you see is the greatest effect is on the gas transfer. So as patients have more severe disease, what you observe is that the gas transfer factor is lower. And this is consistent with what was observed with SARS. Again, there is a reduction in the total lung capacity with more severe disease. But again, the effects that we see on total lung volumes and lung capacity are small in comparison to what we see with gas transfer. And we're beginning to get data from radiology now on COVID-19. And these are data from Canada. And what you can see is that in patients who have had a CT scan 3 months following their COVID-19 infection, and again, these are patients who had no underlying lung disease at time of infection. There is a large number of patients who have evidence of interstitial lung disease, either inflammatory, shown here, or fibrotic, shown here. And in total, 82% of people 3 months following COVID infection had some evidence of interstitial lung disease, and 45% of those had some fibrosis. And based on our experience from SARS, this fibrosis is unlikely to go away. And again, what we see is the effects are predominantly on the gas transfer rather than on spirometry. So what happens if you have pulmonary fibrosis or an interstitial lung disease and you get COVID-19? Well, unfortunately, outcomes are quite bad. These are just data from the UK and European audit of patients admitted to hospital during March and April of this year. And what we observed was that patients who were admitted for non-COVID related reasons had about a 16-17% in-hospital mortality rate. In comparison, in patients who had IPF or had ILD and were admitted with COVID, the mortality rate was over 50%. And when we matched them with age, sex, and comorbidity-related patients who didn't have ILD, we saw that there was an increased risk of mortality, of death, for patients with IPF compared to their controls. but this was most notable in elderly males. So in males over the age of 60, there was a substantial increase in the risk of death from COVID compared with patients who didn't have interstitial lung disease. And when we looked at other risk factors that might increase the risk of dying, we found that patients with ILD who were obese had a twofold increased risk of death compared to ILD patients who weren't obese. And patients who had poor lung function, particularly had an FVC of less than 80%, again had almost a twofold increased risk of death compared with patients who had better lung function. So it's not a huge surprise, but it's the first time that it's been documented that poor lung function is a risk factor for poor outcomes with COVID-19. So what we're trying to understand now is the whole patient journey and the effect of COVID-19 on that. And what we can see here is that there are three groups of people that we're interested in: patients with normal lungs, patients with asymptomatic undiagnosed interstitial lung abnormalities, and patients with interstitial lung disease. And then we need to understand what COVID-19 does to them and how it can affect their illness, either in the community, being admitted to hospital such that they just need basic support, or whether they need advanced support such as oxygen or rarely invasive mechanical ventilation. And then what that does to the interstitial lung disease. Does it develop a new interstitial lung disease? Does the lung disease that they have get worse, or does it all resolve? And certainly it's possible, by understanding the evolution of COVID-related interstitial lung disease, we will get considerable new insights into the evolution of pulmonary fibrosis more generally. So what should we do to try and mitigate these problems? And these are recommendations published from the Canadian ILD community. And many of these things I would agree with, and some of them I would disagree with based on emerging evidence more recently. But some things are fairly standard and non-controversial. So we will use telephone and video appointments wherever feasible, including discussions with ILD nurses. Where possible, we would recommend that everyone, particularly patients more vulnerable of poor outcomes, such as those with interstitial lung disease, maintain appropriate distancing of 2 meters and get delivery of groceries and pharmaceuticals where at all possible. But maintaining social engagement is really important at these times, and certainly online support through FaceTime and web meetings is a good idea, both with family and peers. And this is really important. And the risk to deconditioning is a real one for people who are sort of locked down or shielding, for example. So doing some form of exercise, you don't necessarily have to cycle 10,000 miles, but I did some of those 10,000 miles on a static bike at home. But it's important that you find some way of maintaining exercises and avoiding deconditioning, and that you can't stress that enough. Basic hygiene measures are really important also. So the face, hand washing, and don't touch your face. That's really important, particularly around the nose and the eyes, where there are high levels of ACE2 expression. So very high route of infection. Disinfecting surfaces, less concern with products bought from home. I think the evidence that fomite transmission on cardboard, for example, is not great, but the surfaces that are touched regularly by lots of different people are a problem. Again, handling delivered goods, it's always a good idea to wash your hands, but it's probably no more important than just general hand washing. This is quite controversial. I mean, certainly there is evidence that masks benefit those around you. Whether they benefit the person wearing the mask is a different issue. It is possible that it does reduce dose, and that may be responsible for the slight difference in severity that we're seeing in the second wave. But certainly we would now recommend universal mask wearing unless it is impossible because of the breathlessness and feelings of breathlessness that people with interstitial lung disease may feel. In terms of how we investigate patients with ILD during the pandemic, well, we try and avoid any blood testing which is not absolutely essential. And we certainly did reduce the frequency of blood monitoring for things like nintedanib and pirfenidone during the peak. But that said, it's important to keep an eye certainly on the liver function tests. So we wouldn't want these to be stopped altogether because the information we get is important. But certainly we try and make it more user-friendly, and where possible, we will ask for blood to be taken locally and the results sent to us. We certainly reduced our lung function testing. Again, I think it's important that it is performed, and there will be a move towards home spirometry, and I'll discuss that a little bit. But lung function testing is important, but it may not have to be done within the hospital department. All non-urgent imaging was deferred, but again, we don't normally do chest radiography unless we want to know the result, and we are getting back to doing that even for non-urgent cases. And in terms of avoiding procedures that would not change management, well, we try and do that anyway. And certainly the COVID pandemic didn't really change our practice regarding bronchoscopy and biopsy. We don't do many biopsies, and we would only do them if they would really make a change to our management. And I think this is going to be a big change going forward. This is an article published in the Lancet Respiratory Medicine from Holland, talking about the pros and cons of remote monitoring. And as part of the Injustice study, myself and Fazli Khan, one of my clinical fellows, have been looking at home spirometry. And what we see is that the home spirometry correlates very nicely with the hospital spirometry. You see the straight line here and the correlation. The red dots are patients without IPF but have other fibrotic lung diseases. The blue triangles are patients with IPF, and the results are very similar for both groups of patients, and they correlate. The home spirometry correlates very nicely with the hospital spirometry, suggesting that it would be a feasible alternative for monitoring patients with a range of fibrotic interstitial lung diseases. So what about treatment during the pandemic? Well, I think a big thing to suffer during the pandemic has been pulmonary rehabilitation and other educational initiatives, and that's a real problem. Clearly, it's very difficult to perform pulmonary rehabilitation in groups, and we would not recommend that, but there are ways of doing it online and at home. And again, as I mentioned about deconditioning, it's really important that there are some ways to maintain pulmonary rehabilitation even during the pandemic through virtual provision of services. Again, the sort of repeated testing for supplemental oxygen is probably less important. And then we have to think about how COVID may impact the risk and benefits of continuing interstitial lung disease therapies. And we certainly have a better handle of that on that now than we did at the start of the pandemic. And I think we have a much clearer idea, and I'll discuss that going forward. And then we have discussed this in the UK about how we might modify the eligibility and funding criteria to reflect the difficulty in obtaining pulmonary function tests and undertaking multidisciplinary reviews. And we've had some success, but maybe not as much as we would have liked. And then clearly, when there's a risk of getting an infection, which has a 65% mortality rate in certain patient groups, then deciding in advance what sort of end-of-life planning and referral to palliative care services is important. As I like to say, we need to make our decisions in advance of actually having to act on them, because if you want to maintain control, you don't want to be making decisions in an emergency. So one of the first questions that we were thinking about at the start of the pandemic was, what would steroids do? Would they be good or bad in an acute viral infection? And thanks to the recovery study, the answer is clear. Steroids are good. Certainly 10 days of dexamethasone in patients who have severe COVID reduces mortality. And that doesn't necessarily translate to longer-term steroid use for all patients. People with, who are on 30 milligrams of prednisolone for an inflammatory interstitial lung disease, we can't have the same level of conviction that it would be beneficial, but certainly short courses of steroids are a good thing in patients with severe COVID. What about pirfenidone and nintedanib? Well, it's still difficult to say. At the time, we were concerned that there may be problems. And then there were data from other potential antifibrotic drugs which suggested that, if anything, they could have an antiviral effect by a number of different mechanisms. And certainly when we looked at our audit, certainly for nintedanib, there didn't appear to be a signal that it was harmful. Less clear with pirfenidone. Again, the numbers are very small, so we wouldn't want to draw any major conclusions. There certainly wasn't a huge signal to say that either the immunosuppressants or the antifibrotics were bad, which we found very reassuring, because it meant that we could continue to prescribe these drugs during the pandemic. But we really need to keep monitoring this, because, as I said, the numbers of people who were taking antifibrotics and immunosuppressants who were admitted to hospital with COVID-19 were small. And so, coming towards the end here, I think the big issue that's facing a lot of people right now is the vaccine. And clearly, there's going to be a push, rightly, to administer vaccine to as many people as possible, but there are going to be priority groups. And it's really reassuring to see at last in the UK that within official government documentation, the Green Book, that interstitial lung fibrosis is listed as a specific condition for prioritization for getting the COVID vaccine. So just to conclude, the SARS coronaviruses, including SARS-CoV-2, which causes COVID-19, are pro-fibrotic viruses. People with pulmonary fibrosis will suffer more severe consequences, unfortunately, as a result of COVID-19. Basic measures, including physical distancing, hand hygiene, are really important. Remote monitoring, such as home spirometry, and remote treatment for things such as pulmonary rehabilitation is going to be very important and may actually become standard of care even after the pandemic. And immunomodulatory treatments for interstitial lung disease and antifibrotics are not obviously harmful in COVID-19, may possibly be beneficial, but we really need to do more work on this before we can have a definitive answer. So I'll stop there, and I'll be happy to answer any questions.
Great. Thank you very much indeed, Gisli, for a really, really interesting talk. We've had lots of interesting questions coming up in the chat. The first one is about, you mentioned the SARS-2 vaccine, sorry, the SARS-2 virus, sorry, as being pro-fibrotic. Do you anticipate that with long COVID, we're going to see an increase in progressive pulmonary fibrosis as with IPF? Is it just fibrosis that happens one-off and doesn't progress, or is it progressive?
Well, that's the $100 million question. We don't know. And studies such as FOSP COVID, which you may have heard about on the media, it's the big national initiative led by Leicester, is tasked with answering those questions. So it's possible that it will lead to progressive fibrosis. We don't know yet. But I think I was talking earlier to some colleagues in Europe and the States that as members of the fibrosis sort of physician community, we've become a bit too relaxed about stable disease, and actually stable disease is now regarded as a victory. But actually, what we may find by studying COVID is ways to revert stable disease to resolving disease. And I think so. Although I suspect most post-COVID, long COVID interstitial lung disease will be stable, I don't think we should regard that as a victory, and we should try and help resolution, and which will have big impacts on pulmonary fibrosis research generally.
Yeah, well, that was the next question actually, Gisli, do you think the effects of COVID on will have a positive impact on lungs, will have a positive impact on research that is going to improve our understanding of pulmonary fibrosis?
So I definitely think the latter is true. I think understanding how COVID interacts with the lungs will have major secondary benefits for understanding the biology, natural history, and treatment of pulmonary fibrosis. I certainly don't think COVID will have a positive effect on the lungs generally.
Okay, so but it will possibly feed into improvements in research. I remember in one of your papers you talk about the similarities between the group of patients who suffer worst with COVID generally being overweight, diabetic, the metabolic syndrome idea. Yeah. And you talk about that being typical also of many IPF patients. Is there something there in the middle which is going to drive a better understanding of fibrosis and PF?
Yeah, no, I absolutely think that's the case. I think there are shared mechanisms of disease. I think there's the way we're sort of looking at it now is that there's an evolution of different fibrotic diseases over time, and that's the idea of comorbidities and multimorbidities, and it's like we're talking about the domino theory, that one fibrotic disease begets another fibrotic disease and another one, and if you can prevent the first one or two, you might prevent the development of the most substantial, which is of course lung fibrosis, because it has the one which has got the worst prognosis.
Yeah. Okay. There's been a lot of interesting questions that we had before tonight's webinar, and also one or two come up now about vaccines. I mean, there's a lot of concern. One question here, for example, will COVID vaccines be suitable for pulmonary fibrosis sufferers? There's worry about whether the vaccine itself could be pro-fibrotic with some people, especially those with compromised immune systems in general. So people on immunosuppressants, people, like transplant patients. So what's the answer on that? I mean, are the vaccines safe for both groups? Are they going to be available for both groups?
So the challenge at the moment for all of us in the field is that we haven't seen the totality of the data, because there's such a rush to get the news out there. The data are primarily available through press release, and they are currently being evaluated by organizations such as the MHRA and the FDA, organizations that I have complete faith and trust in. So if the FDA, the MHRA, and the EMA say they're safe within the limits of the data that we have available, then I would certainly accept that. Now, and I have such confidence in that partly because of how these vaccines work. Certainly, the ones that we know about, the Pfizer and the Moderna vaccine are RNA vaccines, and so there's a number of ways that vaccines work, but they essentially try and trick your immune system into thinking you have an infection without you having an infection. And so the most risky vaccines are the live attenuated vaccines, such as the yellow fever vaccine, which is very dangerous if you are at risk. So, for example, you're not allowed to have a yellow fever vaccine if you're over the age of 60. You certainly can't have it if you're immunosuppressed. But neither of the vaccines that are, well, none of them actually, even the Oxford vaccine, these are not live attenuated vaccines. They're the two most effective ones that we've heard of are mRNA vaccines. And these are really cool.
What is that, sorry?
An mRNA vaccine.
Yeah.
And what they do, I mean, it's absolutely brilliant, is they take a small amount of mRNA, which codes only for a specific protein.
This is part of the genetic code, yeah?
Yeah, exactly. Yeah. Sorry. So so rather than create a whole virus, they just, the body creates its own, the human body creates its own spike protein. And then the cells churn out the spike protein, and the immune system thinks that it's infected with a virus, which it isn't. It's just infected with a small bit of protein. But this doesn't go on to cause disease because there's none of the machinery that's required to promote infection, just to promote a body's response to the infection. So it's very unlikely to be fibrogenic. And because it doesn't cause any cellular damage, and it just provokes an immune response. And that in itself is insufficient most of the time to be fibrogenic.
Okay, but for the people on, lung transplant patients on anti-rejection drugs, will the response, will the way in which the immune system be stimulated be the same? I mean, or will a person who, I have a personal interest in this question. Sure. Will a person who's had a transplant on anti-rejection drugs, are they going to still have to be more careful than because their spouses or their partners? Yeah.
So that's a question of efficacy. Unfortunately, I don't know the answer. That will depend on whether patients with transplant were included in the trial. That you can imagine that there may be a diminished immune response, but until we see the data looking at what the effect of the vaccine was in patients with transplant, we won't know if it's any less effective. It won't be any more dangerous. I think that's for certain.
Yeah. I mean, I do notice further down the list in the Green Book, that the table you showed, there's another category of partners of people who are on antisuppressants, immunosuppressants. So my wife is going to be able to apparently get a vaccine at the same time as me. So there's obviously some concern that she needs to have it because it's not going to work well enough for me.
I think there's a general general understanding that no treatment, no vaccine is 100% effective in all people. Yeah. And so to minimize risk to the most vulnerable, you immunize
the people around them
and their partners.
Right. Good. We got an interesting question here about ventilation, essentially saying, is there any research into air conditioning and the environments in which there's no fresh air? Are people with IPF more susceptible when they're in such an environment? In other words, is that a real worry to be in air conditioning only environments?
When you're more susceptible
to COVID, I guess they mean. Yeah.
So I think ventilation is key. I think there is no doubt that if the reason that infections go down in the summer is because windows are open and people are outside. So I would, if at all possible, I would recommend a door and a window open to make sure there's good airflow. I don't know if there's any real evidence that that air-conditioned only environments are more dangerous. I think it depends very much on how that affects airflow. But certainly, ventilation and having good ventilation, really, really important.
Okay. Interesting question here. I've heard you, I think, give the answer. Well, do we know if antifibrotic drugs currently available for IPF will be tested on people with lung fibrosis caused by COVID? Is there any likelihood that they're going to work there too?
So they are being tested in France. They are doing that study. Will they work? I guess if we knew the answer to that question, we wouldn't need to do the study. I think that's so I don't know is the honest answer. Okay.
I hope they give them a bit faster than they have done for IPF patients generally when it comes to it. Are there, well, this one, I believe the normal development and approval of new drugs takes years. Have you any concerns about the speed? This is another question related to safety and efficacy, the speed with which we're moving on these vaccines. I mean, you said, I mean, because obviously, although I agree with you, EMA, FDA, MHRA are, you know, absolutely strong, robust organizations, they are doing this much quicker than they would have done. And with less data, possibly.
So they are, and possibly with less data, and it's always a risk. It's always a risk benefit balance. So I think what we know is that a lot of the other stuff isn't happening. So there isn't the same pressure of other studies being approved at the same time. There's clearly a priority, and that priority is to understand whether or not the vaccines are safe. So the entire focus is rightly on that, and potentially on other trials. Again, if you look at my own sort of clinical environment, there is a real priority on recruiting patients to vaccine studies. I think everyone realizes that the only way out of the pandemic is to get a vaccine that is safe and effective. And so there's a huge amount of resource being put into this at every level, not just at the regulatory environment. So the reason that it's going so much quicker is because there's a lot more investment, there's a lot more person hours at the same time. And also they've been looking at data as it comes. They're not going to get a big wodge of data and then have to look at that in the same time that they might have done previously. There will have been bits coming through. They've been prepared. This is a different environment. So, I mean, clearly, if they will need to have enough data to make a decision, but I do see that they've adjusted their sort of the playing field to give themselves the best chance of doing this properly in the shortest time possible, which you couldn't do unless you had the whole community working together, pulling in the same direction. And I think actually that's one of the really cool things about COVID is it just goes to show what the community can achieve when it all focuses on a single goal and pulls together for a single reason.
Actually, following on the vaccine question again, this is I'll ask the question. With the emergence of new vaccines such as the Oxford AstraZeneca vaccine, which releases T cells into the body's immune system at the end of the immunization process, do we know whether these T cells are pro-fibrotic or anti-fibrotic and are likely to cause any worsening of lung scarring? Again, it's a question from an IPF patient worried about whether to take the vaccine or not.
Yeah, again, it's hard to say up front without seeing good data. All I'd say is the activation of T cell mediated immunity is not particularly new. Targeting it on coronaviruses is the key thing. but vaccines which use cell-mediated immunity are not new for other diseases. And vaccines which have stimulated T-cell immunity for other diseases haven't caused a problem in IPF. So it would be a real surprise to me if, because it was targeting a coronavirus rather than, say, a herpes virus, for example, that it would cause different problems. So I'm not unduly concerned, but I would always advise people remain are vigilant.
I mean, is it more likely that pulmonary fibrosis patients will be given one of the 2 American vaccines rather than the Oxford one, as likely to come online first or anything? Or
I don't, not as far as I'm aware. And I think, remember, I think that the flip side is not whether or not you get a vaccine or nothing. The argument is which is more pro-fibrotic, getting coronavirus or having a vaccine. There is no argument.
Yeah. And a question here, which I think I know the answer to: did any ILD patients take part in any vaccine trial? And the
I don't know is the honest answer.
Okay. It's unlikely, is it? Or
I honestly don't know. You'd have to look at the data, and that's part of the trouble. We don't know. I would be surprised if there were no IPF patients taking part in them.
But we're so good at shielding that we wouldn't be very good subjects, would we?
Well, they were voluntary. It depends on people who took that chance. We know that there certainly were elderly people who took part who were at risk of coronavirus. But I don't know. I haven't got those data.
Okay. A gentleman says, I'm booked in for minor surgery next or later in the month. Should I have this procedure if I suffer from IPF? In other words, is the risk of going into hospital for minor surgery?
It depends, I guess, on the country, the hospital, the procedure, and what. I think at the current time, the R in the UK, I don't know what the geographical location of this person is going down. We have reasonably robust infection control procedures, and it depends very much on what the surgery is for. Something, as a general rule, personally, I'm not a big fan of any minor surgery, but it depends very much on what it's for and what happens if you don't have it.
Yeah. It's interesting. I keep seeing my friends' names coming up here, but we've decided not to give any name because it stops the ease of sharing it afterwards. But what are your thoughts on antibody testing?
For coronavirus?
Presumably, yeah, afterwards, yeah.
Well, I think it's useful for figuring out the whole burden of disease nationally. From an individual's perspective, it's not necessarily particularly useful. It gives you an idea that you've been infected if your antibodies are positive. So certainly if you have symptoms of long COVID and you want to know if you've had COVID, then an antibody test is useful. It's not going to tell you whether you're immune, unfortunately. So from that point of view, it's not particularly helpful. But if you want to know whether or not you've had COVID, it's a reasonably good test for that.
Okay, thanks. There's another question from about post-COVID fibrosis. And essentially it boils down to, is it mainly due to ARDS, to the acute respiratory distress syndrome, which is largely related to having been ventilated, or is it due to something inherent in the virus itself, which is a little bit like the study today, the Xenon study that was in the paper and the BBC?
No, that's a great question. Short answer is no, I don't think it's all related to mechanical ventilation. Certainly we know from patients who develop ARDS and are mechanically ventilated are at high risk of developing a ARDS-related fibrosis. We've recognized that for quite a while. but we are seeing, unfortunately, quite a lot of fibrosis which is not related to mechanical ventilation. And I won't go back to the slides, but in the Canadian study distinguished patients by whether or not they'd been ventilated, and it didn't make a huge amount of difference. And we're certainly seeing plenty of patients, unfortunately, who were never ventilated getting fibrosis down the line.
Fine, yeah. I mean, there's concern about what the point you made, which I wasn't aware of, about that the impact is mainly on diffusion, gas diffusion, TLCO, not on lung volume. And saying, look, if I've got low TLCO already, and I get COVID, it looks bad news for me. Is there anything I can do to stop or boost my diminishing gas diffusion levels?
So get a vaccine and don't get COVID. That's unfortunately, that's the only way to really protect your lungs at the moment, short of the sort of practical measures of shielding, hand hygiene, avoiding the virus. But if you get COVID, unfortunately, there's nothing we can do to protect our gas transfer. It's a very it is unfortunately what it is. It's if you damage your alveolar capillary unit for whatever reason, through infection, or if it's already damaged, we can't specifically make it better. So again, so
it's the damaging of the lining of the little air sacs, basically. By the virus.
The air sacs itself. So in fibrosis, they're thickened, because they have because of the scar, but also they can get clots in them, and they can get destroyed by emphysema. So there's a bunch of reasons why the gas transfer reduces. But generally, it's best avoided if you can. But there's nothing you can do other than avoiding the condition that causes it, if you see what I mean. It's not like you can't recondition some other part of the body to make up for that.
Okay, and I'll just remember I lost the UK government. I'll come to that one in a moment. Some of the questions are going in odd places. There was a question about dexamethasone and whether it would be fibrotic. Is there any evidence that dexamethasone reduces the degree of fibrosis post-COVID?
So a great question. We don't know.
It is from a doctor, actually.
we don't know.
Yeah.
We intuitively think it probably does.
Yeah.
And so I know that some places are using dexamethasone and steroids more long-term to try and reduce the risk of long-term complication in patients where there is evidence of interstitial lung disease at discharge. But we really need a study to address that question, because the long-term effects of steroids are not trivial.
Yeah. And
I would certainly recommend that such a trial is done. And I think one is being conceived.
No, that's great. Final question, Gisli. There are a few more that we'll have to deal with afterwards in writing. So apologies to those of you who are a bit further down the list. But somehow a friend of mine has jumped to the top of the list, and he's put this question in. The UK government has relaxed its rules over Christmas so that we can meet our families. What would be your advice to pulmonary fibrosis patients?
Again, it's a risk benefit analysis that everyone has to make on their own. There will be an increased risk of transmission. There is no doubt about that. But that's on a population level. We know that the virus loves social contact. It transmits through close interactions. Anything you can do to reduce that will reduce the risk of transmission. But that said, Christmas is an important family time, and people as well as viruses need social contact. So I don't think there's a right answer, unfortunately. People have to make their own risk assessments. Clearly, if anyone has symptomatic evidence of infection, they really should not mix with anyone at Christmas. But people will have to make their own decisions on this.
Yeah, and I guess it depends partly on your assessment of how quickly the vaccine's going to come. Could we have Christmas in April instead of December? You know, those are the sort of things we're asking in our family. Yeah,
I think you can delay. You know, if there are, I mean, there is no doubt that transmission will be made worse by Christmas. It's whether that's a price that individuals in society are prepared to pay for what is an important annual festival.
Great. Well, Gisli, that's fantastic. Thank you very much. There have been a number of laudatory and congratulatory messages in the Q&A as well, saying what a great webinar it's been. I'd like to thank you very much on behalf of all of us for this really excellent talk and for stimulating such a great discussion. Obviously, we're all a bit neurotic about vaccines at the moment, so you had more vaccine questions than you might have had 2 weeks ago. But this was a fantastic start to our webinar series. Thanks to all of you who asked questions. There are 133 people in the webinar tonight, which is a nice number. Far more than we thought. We'd be lucky if we possibly made 100. We hope very much that those of you who've come have enjoyed the evening and will come to future events. We'll be putting the details on the EU IPFF website shortly. As I said earlier, this has been recorded and we're going to be issuing it in 5 other languages with subtitles within a couple of weeks, because we're conscious of the fact that for a pan-European audience, dealing only in spoken English can be problematic for an audience of patients. So hopefully, if you have friends in France, Germany, Italy, Spain, it's coming. It'll be coming in national languages. Finally, I'd like to thank the Patvicates team. As some of you will have seen the word Patvicates up here. Patvicates is the small company that provides our secretariat to EU IPFF. I'd like to especially thank Jan and Samantha and Hamza and Alba, 4 of them, for all the work they did to make this possible tonight. Many thanks to everybody for coming, and have a very pleasant evening. Gisli, thank you very much indeed.
Thank you.
You get 1 clap anyway. Great. Thank you.